Welcome to Pleasant View's training for human rights in the DD community. This will be a general overview of what the human rights are and the two regulatory bodies that oversee human rights for individuals with intellectual disabilities. So those two entities are the Virginia Department of Behavioral Health and Developmental Services, or DBHDS, as well as DMAS or HCBS. DMAS stands for the Department of Medical Assistance Services, and HCBS stands for Home Community-Based Services. We'll begin with the state level of regulations. So the department I'm referring to is the Department of Behavioral Health and Developmental Services, or DBHDS. That department is further broken into different offices. So the Office of Human Rights, the Office of Licensing, Office of Integrative Health. So for this presentation, I'm going to be talking about the Office of Human Rights. Furthermore, the state has been broken into different regions, and each region has their own advocate. There are 5 regions in Virginia. We are in Region 1, which is kind of the northwest section, so north to Winchester, then down to the Lexington Rockbridge area. And our advocate, her name is Cassie Pertlebaugh. So the Department of Behavioral Health and Developmental Services oversees the human rights regulations, which is Chapter 115 of the Virginia Code. And they're entitled Regulations to Assure the Rights of Individuals Receiving Services from Providers Licensed, Funded, or Operated by the Department of Behavioral Health and Developmental Services. That is a mouthful, so I just refer to them as the human rights regulations. These regulations apply to all individuals receiving services from any providers licensed, operated, or funded by DBHDS. So what is their mission? The mission of the Office of Human Rights is to monitor compliance with the human rights regulations by promoting the basic precepts of human dignity, advocating for the rights of persons with disabilities in our service delivery systems, and managing the DBHDS Human Rights Dispute Resolution Program. So in summary, their mission is to ensure that individuals have their human rights met and honored. They advocate for the rights of people with disabilities, and then they manage any disputes within their delivery system. They also want to promote respect for human dignity and assure that services are provided consistent with sound therapeutic practice. And they do this by protecting individuals, promoting person-centered services amongst the providers, and then providing a check and balance between providers and individuals receiving services. So some of the key terms and definitions that you'll hear me use throughout this presentation. Abuse means any act or failure to act by an employee or other person responsible for the care of an individual in a facility or program operated, licensed, or funded by the department that was performed or was failed to be performed knowingly, recklessly, or intentionally, and that caused or might have caused physical or psychological harm, injury, or death to a person receiving care or treatment for mental illness, intellectual disability, or substance abuse. Examples of abuse include acts such as rape, assault, or other criminal sexual behavior, assault or battery, use of language that demeans, threatens, intimidates, or humiliates the person, misuse or misappropriation of the person's assets, good, or property, use of excessive force when placing a person in physical or mechanical restraint, use of physical or mechanical restraints on a person that is not in compliance with federal and state laws, regulations, and policies, professionally accepted standards of practice, or the person's individualized service plan, as well as use of more restrictive or intensive services or denial of services to punish the person or that is not consistent with his individualized service plan. So essentially, abuse is any act that could harm or that did result in harm or could result in harm. It can be physical in nature, it can be emotional or mental. Exploitation means the misuse or misappropriation of an individual's assets, goods, or property. Exploitation is actually a type of abuse. Exploitation also includes the use of a position of authority to extract personal gain from an individual. Exploitation does not include the billing of an individual's third-party payer for services. Exploitation also does not include instances of use or appropriation in an individual's assets, goods, or property when permission is given by the individual or his authorized representative with full knowledge of the consequences, with no inducements, and without force, misrepresentation, fraud, deceit, duress of any form, constraint, or coercion. So neglect means failure by a person, program, or facility operated, licensed, or funded by the department responsible for providing services to do so. This includes nourishment, treatment, care, goods or services necessary to the health, safety, or welfare of an individual receiving care or treatment for mental illness, intellectual disability, or substance abuse. Peer-on-peer aggression means a physical act, verbal threat, or demeaning expression by an individual against or to another individual that causes physical or emotional harm to that individual. Examples could include hitting, kicking, scratching, and other threatening behavior. Such instances constitute potential neglect. So peer-on-peer aggression could actually be a form of neglect, because when we're looking at the environment of why that peer-on-peer aggression may have happened, or that peer-to-peer incident may have happened, we're looking at ourselves to see, were we negligent in not providing the right services? So the state has really pushed providers to do more training on sexual violence. Sexual violence is a crime of violence, anger, power, and control where sex is used as a weapon against the victim. It includes any unwanted sexual contact or attention achieved by force, threats, bribes, manipulation, pressure, tricks, or violence. It may be physical or non-physical and includes rape, attempted rape, incest, and child molestation and sexual harassment. It can also include fondling, exhibitionism, oral sex, exposure to sexual material such as pornography, and the use of inappropriate sexual remarks or language. Sexual violence can occur in the home, outside the home, on the job, and virtually anywhere. Again, like abuse, sexual violence can be physical in nature, it can be emotional, psychological. There's two types of sexual violence. There's sexual assault and sexual abuse. Sexual assault is essentially like a one-time incident. Sexual abuse is a pattern of incidents or a pattern of behavior. So it is something that has happened to the individual multiple times. It's not an isolated incident. The reason the state has been pushing for more training on sexual violence is because people with disabilities are assaulted at a much higher rate than people without disabilities, and people with intellectual or developmental disabilities are assaulted at an even higher rate than somebody that may have a physical disability. A few more statistics regarding the rates of sexual violence in this population. 83% of women with disabilities will be sexually assaulted in their lives. Just 3% of sexual abuses involving people with developmental disabilities are ever reported. Approximately 80% of women and 30% of men with developmental disabilities have been sexually assaulted. Half of the women have been assaulted more than 10 times, so they are victims of sexual abuse because that behavior has happened more than once. Here's a couple graphs to kind of just demonstrate how dramatic the rates are for people with intellectual disabilities. This top bar, or this top chart, this blue bar, is persons with intellectual disabilities, and you can see how they're assaulted at about a 4 times higher rate than people that do not have disabilities. And then you can see how dramatically different it is by gender. So women with intellectual disabilities are victims of sexual violence about 7 times higher than men with intellectual disabilities. To summarize some of the bullet points of the sexual violence part of this training, again, people with intellectual disabilities are sexually assaulted at much higher rates than those without disabilities. People with intellectual disabilities are at a heightened risk at all moments of their lives. They are more likely to be assaulted by someone they know, and it's also more likely to happen during daytime hours. Individuals or predators target individuals with intellectual disabilities because they know they're easily manipulated or can be, and will have difficulty testifying later. These crimes go mostly unrecognized, unprosecuted, and unpunished, which makes the abuser free to abuse again. Police and prosecutors are often reluctant to take these cases because they are difficult to win in court due to an individual's difficulty in testifying, or a family's reluctance to allow their individual to be interviewed or testify in court. So what are some of the warning signs of abuse? So changes in behavior, for example, refusing to go places or engage in activities they usually like to do. Changes in emotional state, so if the person becomes more withdrawn, they start to display more signs of anxiety or depression. And a little bit of a caveat here, I'm not saying that every change in behavior or change in emotional state is a direct result of abuse or neglect. whenever somebody does have a change in their baseline or a change in their behavior, we're essentially doing like a two-prong approach to figure out what it is that's going on. We are looking at the environment to see if any changes in the environment could be causing this change in behavior, but we're also looking at anything internally that could be going on. Could this person was there a medication change? Could they be fighting off an infection or have a new source of pain? UTIs, or urinary tract infections in particular, have pretty dramatic impacts on individuals with disabilities as far as their behavior goes. In my personal experience, I've known individuals that never had any, psychological concerns start to have delusions or hallucinations when they had a UTI. So again, it's a two-prong approach to look at the environment and then also anything that might be going on medically with the individual to see if that could be causing any of these changes in behavior or emotional state. Some of the more obvious signs of abuse would be unexplained cuts, bruises, bleeding, broken bones, burns, over-medication, or isolation. And isolation, you will see that as a warning sign for just about everything, any type of human rights violation, because the perpetrator or the person that is violating the person's human rights will often isolate the person to make sure that they are less likely to be caught. So some of the warning signs of neglect include dehydration or malnourishment, poor hygiene, for example, dirty clothes, dirty hair, a bad body odor, again, isolation, lack of food and other amenities in the home. Does that individual not have food that they like there? Do they not have proper clothing or proper bedding? Unexplained weight loss, pressure sores, unpaid bills, lack of proper medical care or treatment, animal or insect infestation in the home. And again, I'm not saying that all of these signs always mean that there is neglect going on, but that's going to be one of the things that we're looking at. But we would also be looking to see if there's any type of medical reason that could be causing the unexplained weight loss or the dehydration. Again, exploitation is a form of abuse, but some of the warning signs for exploitation are going to be different than what you would see for physical or emotional abuse. So some of the warning signs of exploitation are withdrawals of significant amounts of cash from bank accounts, forged checks, unexplained or unknown credit card usage or other charges, unpaid bills, unfamiliar creditors. But again, you'll see isolation could also be a sign of exploitation. So what are some abuse prevention strategies? First and foremost, know the warning signs so that way you can provide intervention as needed. Also using person-centered language. Mary has autism versus Mary is autistic. This humanizes the person and doesn't objectify them or equate them to their disability. Engage individuals with self-advocacy programs so that they can learn how to advocate for themselves or speak up for themselves. Support individuals with develop a community. If you recall, isolation was a warning sign for abuse, neglect, exploitation. So the more people that are involved with an individual's life, the more people that are able to look out for them. Also helping individuals understand and develop healthy personal boundaries so that they are able to tell what's inappropriate touch or what's an inappropriate relationship and what is a healthy relationship. So moving along and still within the DBHDS Office of Human Rights Regulations. So abuse, neglect, and exploitation, that's kind of the black and white of human rights. Now moving into the freedoms of everyday life, these seem to be a bit more gray. So the freedoms of everyday life are, this is essentially individuals have the right to enjoy all the freedoms of everyday life that are consistent with his need or services, his protection and the protection of others, and that do not interfere with his services or the services of others. Now these are going to kind of sound like, to you and me, they're going to kind of sound like responsibilities or chores, but these were things that were denied to individuals for so long and are really opportunities for them to be independent and be autonomous. So these freedoms include freedom to move within the service setting, its grounds, and the community. Freedom to communicate, associate, and meet privately with anyone the individual chooses. Freedom to have and spend personal money. Freedom to see, hear, or receive television, radio, books, and newspapers, whether privately owned or in a library or public area of the service setting. freedom to keep and use personal clothing and other personal items, freedom to use recreational facilities and enjoy the outdoors, and freedom to make purchases in canteens, vending machines, or stores selling a basic selection of food and clothing. Again, freedoms of everyday life is just that. It's the little things that you and I do every day without thinking about it. These were things that when individuals were institutionalized, or maybe they had a lot of restrictions due to their behaviors, these were not things that they were able to engage in. All right, so shifting gears a little bit, we're going to talk about some things that may have an impact on how individuals are able to exercise their rights. And one of those things is consent. So consent means the voluntary agreement of an individual or that individual's authorized representative to specific services. So basically an individual agreeing to receiving services. They're saying, I want that service if they're giving consent. Consent shall be given freely and without undue inducement, any element of force, fraud, deceit, or duress, or any form of constraint or coercion. Consent may be expressed through any means appropriate for the individual, including verbally, through physical gestures or behaviors in Braille or American Sign Language, in writing, or through other methods. So informed consent means the voluntary written agreement of an individual or that individual's authorized representative to surgery, electroconvulsive treatment, use of psychotropic medications, or any other treatment or service that poses a risk of harm greater than that ordinarily encountered in daily life, or for participation in human research. To be voluntary, informed consent must be given freely and without undue inducement, any element of force, fraud, deceit, or duress, or any form of constraint or coercion. So the best example I can give for informed consent is for medications. So I can give informed consent if I understand that I'm taking this medication for this reason, and these are the possible side effects, and then these are the alternative treatments. But then if I don't take this medication, I may, my condition may worsen or may not improve. So if I can do those things, then I can give informed consent. And informed consent must be written. If you think back to the HIPAA training, we can get verbal consent or verbal informed consent if there's a need for immediate action, but then it has to be followed up with written consent. Okay, so some definitions or terminology regarding consent. Authorized representative means a person permitted by law or this chapter being the Office of Human Rights Regulations, to authorize the disclosure of information or to consent to treatment and services or participation in human research. The decision-making authority of an authorized representative recognized or designated under this chapter is limited to decisions pertaining to the designated provider. Legal guardians, attorneys in fact, or healthcare agents appointed pursuant to this code may have decision-making authority beyond such provider. So essentially what that means is that if an individual does not demonstrate the ability to give consent or provide informed consent, they need to have a substitute decision maker, which could be an authorized representative. An authorized representative would be somebody that has a relationship with the individual that is an unpaid support. So it can't be somebody that is paid to work with that individual or paid to provide any type of support to that individual. So it can't be, it can't be like a staff member. So the role of the authorized representative is to support the individual in making decisions or providing consent, and then also communicating those preferences to other providers. An authorized some Pleasant View terminology, a lot of times you'll hear me use the term substitute decision maker or SDM. That's kind of an umbrella term for an authorized representative, a guardian, or a POA. So how a guardian is different from an authorized representative: if an individual has an authorized representative, they maintain all of their legal rights. If they have a guardian, they will lose some of their rights. A guardian is someone that has petitioned the courts to have the individual seem incompetent in some way, whether that be financial or medical, and then the court has essentially agreed, and then the individual is appointed a guardian. Guardianship usually happens when an adult wants to maintain, or an adult parent wants to maintain guardianship of their a disabled child as they reach adulthood. Sometimes we have individuals that have guardians due to abuse situations. So maybe the state has appointed them a guardian to protect them from, family members or prior abusers. And now if an individual has a guardian, and then they do lose some of their rights, typically things like the right to vote, the right to choose who their doctor is, but it depends on the type of guardianship. So not only is it important to know if your individuals have a substitute decision maker, it's important to know what type it is. And then POA down there at the bottom of the slide stands for power of attorney. This, again, there is legal paperwork that goes along with this. POAs are usually for either financial or for medical decisions only. Okay, a few more notes about consent. Consent means the right to participate meaningfully in decisions regarding all aspects of services, including medical treatment. So individuals have the right to participate in all the decisions regarding their treatment. Individuals also have the right to be accompanied by someone the individual trusts when participating in service planning, whether or not that person be an authorized representative or a guardian. If an individual wants to invite people to their meeting or to a doctor's appointment, that's their right to do so. Individuals also have the right to have a legally authorized representative, such as a guardian or a POA, appointed when the individual is incapable of making certain decisions. So that could be for, maybe a POA will only come into play when there's a medical emergency or something like that. But individuals do have the right to have an advocate make those decisions for them in some situations. All right, so participation goes hand in hand with consent. Participation must be documented and should include evidence of preferences. Preferences in their very nature require more than one option and therefore indicate choice and participation. The absence of preferences shows a lack of person-centered services. So in order for an individual to provide consent, they need to be aware of what their choices are. And those choices and preferences need to be documented in their support documentation. All right, so switching over to restraints. So this is also something that will have an impact on individuals' rights. So restraint means the use of a mechanical device, medication, physical intervention, or hands-on hold to prevent an individual from moving his body to engage in a behavior that places him or others at imminent risk. There are three kinds of restraints. There's a mechanical restraint, which means the use of a mechanical device that cannot be removed by an individual to restrict the freedom of movement or functioning of a limb or a portion of the individual's body when that behavior places him or others at an imminent risk. There's a pharmacological restraint. This is the use of a medication that is administered involuntarily for the emergency control of an individual's behavior when that individual's behavior places him or others at imminent risk, and the administered medication is not a standard treatment for the individual's medical or psychiatric condition. So for example, a lorazepam that an individual receives at 5 o'clock every day and as a scheduled medication is not considered a pharmacological restraint. Now, a lorazepam that is given as a PRN that they don't have to provide consent to, that could be a pharmacological restraint. So and then the third type of restraint is a physical restraint. This is also referred to as a manual hold, meaning the use of a physical intervention or hands-on hold to prevent an individual from moving his body when that individual's behavior places him or others at imminent risk. We do not have any physical or pharmacological restraints at Pleasant View. We may have mechanical restraints. So in addition to the three types of restraints, there are three purposes for restraints. The first being restraint for behavioral purposes. This means a physical hold, medication, or a mechanical device to control behavior or involuntarily restrict the freedom of movement of an individual in an instant when all the following conditions are met. So there's an emergency, non-physical interventions are not viable, and safety issues require immediate response. Then there's restraints for medical purposes. This means using a physical hold, medication, or mechanical device to limit the mobility of an individual for medical, diagnostic, or surgical purposes, such as routine dental care or radiological procedures and related post-procedure care processes, when use of the restraint is not the accepted clinical practice for treating the individual's condition. So this may be if an individual would need to be restrained to have a dental procedure done or to have like a CT scan or something of that nature. And then finally, restraints for protective purposes. This means using a mechanical device to compensate for a physical or cognitive deficit when the individual does not have the option to remove the device. The device may limit individuals' movement, for example, bed rails or a jerry chair, and prevent possible harm to the individual, or it may create a passive barrier, such as a helmet, to protect the individual. So this is the most common restraint that you'll see at Pleasant View. Yeah, I'm having a hard time thinking of examples of the other two, because the restraints for protective purposes are what you're going to see the most of. So again, a helmet, individuals may wear helmets because they have a seizure disorder, and the helmet is to protect them if they were to fall during a seizure, or maybe they have hand mitts to prevent them from putting their hand in their mouth and regurgitating or scratching at something. And again, bed rails, those are going to be the most common restraints that you see are mechanical restraints for protective purposes. Emphasizing that Pleasant View does not use seclusion or manual restraints. Okay, so then related to restraints are restrictions. Restrictions mean anything that limits or prevents an individual from freely exercising his rights and privileges. So there's 3 types of restrictions: program responsibilities, restrictive treatment plans, and behavioral treatment plans. So the first type of restriction is a program rule. Program rules apply the same to all individuals receiving services in the program to maintain a safe and orderly environment. So program rules are reviewed with individuals when they are looking at our services, and then they're reviewed and signed prior to admission or when they decide to receive services. And program rules, they can be different for every program. So day program rules are going to be different from a residential program rules, but they do apply to all individuals the same. When program rules are written or when they're changed, we have to get suggestions from the individuals. Again, they apply to all individuals. They are given to the individuals. They also need to be posted. So the next step up in intensity from program rules are restrictive treatment plans. So whereas program rules apply to all individuals in a program, restrictive treatment plans are individualized. They are written for an individual for a specific concern. So restrictive treatment plans may happen when an individual is engaged in a behavior that may cause harm to themselves or cause harm to others. For us to write a restrictive treatment plan, we have to identify what the behavior is and what the possible or actual harm being caused is. They have to be written by a qualified professional, and the regulations define a qualified professional as anyone who has experience working with that individual as well as experience within this field. So to write the restrictive treatment plan, in addition to identifying the behavior and identifying the harm, we have to record or document all possible alternatives to the proposed restriction, and that we have to show that we have assessed all those and have documented those, because individuals have the right to be treated in the least restrictive environment. We also have to document that we've determined that the proposed restriction is necessary for effective treatment to the individual or to protect him or others from personal harm, injury, or death. We have to document in the individual services record the specific reason for the restriction. We also have to explain to the individual what that restriction is, why they are having that restriction, and also the criteria for removal. So what behaviors does the individual need to develop, or what skills do they need to learn in order for us to remove this restriction? It has to be regularly reviewed, and it has to have an end date. So we can't just indefinitely put a restriction in. We would have to say we are going to put this restriction in place for 3 months or 6 months. And then we'll review it monthly, or we'll review it quarterly. And then if the behavior hasn't stopped by the proposed end date, we have to kind of reassess and say, what do we need to do differently, or what other type of restriction can we put in place in order to protect this individual. So restrictive treatment plans have to be written They also have to be approved by the LHRC, excuse me. And the LHRC stands for the Local Human Rights Committee. If you remember in one of the earliest slides, I said that the state of Virginia is broken into 5 regions, and we are in Region 1. So each region has at least one LHRC or one local human rights committee, and the local human rights committee is made up of volunteers, of people that have experience with this field, whether they have received services or are related to someone that has received services or work in the field or have worked in the field. They have to have experience within this field. And they meet regularly, whether that be quarterly or monthly, and they review any human rights concerns in the area. So that could be any restrictions, any authorized representative designations, any appealed investigations, which I'll get into in a little bit. But any restrictions have to be approved by the LHRC if they last longer than 7 days or imposed 3 or more times during a 30-day time period. All right, next is a behavioral treatment plan, and these are fairly similar in composition to restrictive treatment plans, except that the main difference with a behavioral treatment plan is that they have to be written by a licensed professional. So in addition to experience in the field, licensed professionals also have to have additional credentials, such as being a licensed clinical social worker or a licensed clinical psychologist, or they could be a PBS facilitator, which stands for Positive Behavioral Supports. So in addition to experience, they have to have credentials, specific credentials as well. So behavioral treatment plans are used to assist an individual to improve participation in normal activities and conditions of everyday living, reducing challenging behaviors, alleviate symptoms of psychopathology, and maintain a safe and orderly environment. But kind of the same principles apply to behavioral treatment plan, that we have to identify what the behavior is, what the least restrictive environment has been, what the restriction may be, and then it has to be reviewed regularly. Okay, so what happens, so switching gears a little bit to what happens if you suspect a human rights violation, or if there is a complaint or human rights allegation. So everyone that works in the human services field gets the distinction of being a mandated reporter. So you must report any suspected abuse, neglect, or exploitation, whether that be professionally or personally. So if it happens at Pleasant View, it needs to be reported, or if it happens outside of Pleasant View, it also has to be reported. So if it happens outside of Pleasant View, you can report to the Department of Social Services, that's DSS. If it involves someone over the age of 18 or older, you would report to APS, which stands for Adult Protective Services, or CPS, that's Child Protective Services, if it's someone that's under the age of 18. There are protections in place for mandated reporters. So if you were to report something and it was found not to be a human rights violation, or not to be abuse or neglect or exploitation, you won't be punished for that. But there are consequences for if an investigation were to occur and it was found that you knew about it but you didn't report it, and those are typically monetary consequences, so fines. We do have protocols in place for if there is an allegation of human rights that occurs at Pleasant View. So first and foremost, your number one priority is the health and safety of the individual. So this may mean that you may need to intervene or interrupt a coworker or call 911. And then once the individual is safe, then you can immediately report any suspected human rights violation to either the program social worker or directly to your supervisor. Keep reports confidential, so do not discuss your experience with coworkers, and that could be tricky because it can be traumatizing to think that you have witnessed abuse, especially if it's abuse by a coworker. But we request that you not discuss these feelings with other coworkers or anyone else at Pleasant View in order for us to do an accurate investigation. If you do feel that you would like to speak to someone to talk about the experience, we can connect you with human resources to see about taking advantage of the EAP. So once you've reported it, the certified investigators will take over, and that is both social workers, so Lindsay Allison, and then also myself. We have had further training with the Office of Human Rights in an investigation, as well as human rights trainings. So we are all certified to do investigations. So what we will do is notify the individual and their substitute decision maker and begin investigation by the next business day. We also have to report the allegation to the state via the CRIS system, which is the Computerized Human Rights Information System, within 24 hours. So that's why it's so important that you report it as soon as it is safe to do so, because there is some information that we have to acquire in order to complete that computerized report. During the investigation, we will interview all relevant parties, so the reporter, any possible witnesses, and of course the individual themselves and the person that is alleged against. And we have to complete the investigation within 10 days and then notify the individual, their substitute decision maker, and then the state of what our findings are and any corrective action. Okay, moving from the state level of regulations to the federal level of human rights regulations, now we're going to talk about HCBS, or Home and Community-Based Services. These are the regulations that come from the Center for Medicaid Services, so that makes them federal regulations. Basically, what they are is it requires that people receiving services through Medicaid HCBS waiver programs have full access to community life and are able to receive services in the most integrated setting possible. Medicaid enrolled providers must be compliant with HCBS practices in order to receive funding. So basically what that means is that we have to follow all of the standards set out by HCBS in order to receive payment for the services that we're providing. There has been questions on whether these rights are already covered within the DBHDS human rights regulations and requirements, but HCBS rights go beyond human rights. While there is some overlap, HCBS rights are more specific. They are afforded specifically to individuals receiving Medicaid HCBS, and it's important that individuals and their families know their HCBS rights and how to exercise those rights. There are 5 standards to HCBS. Integrated setting supports access to community, individual choice of settings, individual rights, so privacy, dignity and respect, and freedom from coercion and restraint. Autonomy optimizes but does not regiment individual initiative, autonomy, and independence. And then choice regarding services and providers. The first setting is integration. This means that the setting must be integrated in and supports full access to the greater community. So essentially this means wherever the individual is receiving services, whether that be day support or a group home or supported living, apartment type setting, they need to be able to access the community around them. So how do we do this? We offer individuals in each service opportunities for social engagement, either through volunteer work, joining a civic group or interest groups, participating in public events such as political rallies or volunteer activities. Individuals also have supports with controlling their personal resources, i.e. going shopping, going out to eat at restaurants, support with budgeting. And then finally, to receive services in the community. So, instead of a doctor coming to them, they go out to the doctor's office. They have support with obtaining benefits such as disability, Social Security, or EBT, or any other type of benefit. Next is choice. The setting must facilitate individual choice regarding services and supports and who provides them. So how do we do this? We regularly check with individuals about their satisfaction with the supports that they receive, and then we document it. It can be documented daily in the progress notes, and this could be something as simple as individual was asked if they wanted lasagna or pad thai for dinner, and then what did they choose? Or individual was offered different activities to do this afternoon, like playing a board game or doing laundry or watching TV, and they chose to play this board game. We also document it in their quarterly reports or their person-centered reviews, and we have specific questions worked into those reports that address the satisfaction with services. And we also do this annually. We do this through their rights and releases, which is done by the social work department, as well as informed choice and their individual services plan. The third HCBS standard has to do with individual rights. So this one is: the setting must ensure an individual's rights of privacy, dignity and respect, and freedom from coercion and restraint. This includes respecting people's likes and dislikes, talking with people in a way that makes them feel respected and heard, and assisting people with personal supports in a compassionate manner that preserves their privacy and dignity. So this really boils down to knowing your individuals, knowing the things that they like, knowing how they want supports, knowing what types of supports they want, and just knowing the best way to talk with them. A few definitions real quick. Privacy. This one, while the definition of privacy is pretty obvious, it can be a little bit of a spectrum for some of the individuals that we support. We have some individuals who maybe don't have a huge concept of privacy. An example of that might be an individual who wants to, walk naked from the bathroom after taking a shower down the hall to their bedroom. We want to support the dignity of everybody in that house. So and protect that individual's privacy. So we encourage them to put a robe on, or, put their pajamas on or put their clothes on while they're in the bathroom before they before they leave the bathroom. And then we have individuals on the far end of the spectrum who maybe are intensely private, but might need supports in some aspects to keep themselves healthy and safe. So for example, like a bedroom, keeping a bedroom clean. Maybe some individuals are very private and they don't want anybody in their bedroom, and that's absolutely fine if they can keep their bedroom clean and tidy and free of pests or any tripping hazards or safety hazards. Now, if an individual is not able to do that, then we as a provider have to provide supports to help them in maintaining a healthy environment. So again, we would meet them to what their ability is. So, we would work with them in setting up a schedule for when it's going to be cleaned, support them in doing as much cleaning as they can, or, cleaning the space for them if needed. Coercion. Coercion can sometimes be confused with exploitation. The definition of coercion is to make someone do something by using force or threats, to get something by force or threats. And this could also be manipulation. So coercing somebody to do something to make your job easier, either by forcing them or threatening them or manipulating them. Restraints, we reviewed those already. So some examples of the how. For privacy, we knock before entering bedrooms. We keep doors closed when doing direct care, such as assisting somebody with getting dressed or using the restroom. Dignity, we foster community options and choices. Respect, we obtain consent. We engage in meaningful discussions with the individual during meetings, as well as doctor's appointments or any other type of appointment. Coercion, we ensure choice in all aspects of an individual's life, offer different options to individuals, can make more informed choices. So, ensure choice in all aspects of individual's life. That essentially means not only is it the big picture stuff like who they're receiving services from, but what they're wearing that day or what activities they're doing that day. And then finally, restraint. Again, it's only as a means to protect individuals and or others, and only following proper procedure and guidelines, which I talked about earlier. Okay, the next standard is individual autonomy, and the standard for this is: the setting must optimize but does not regiment individual initiative, autonomy, and independence in making life choices, including but not limited to daily activities, physical environment, and with whom to interact. So how do we do this? We promote independence. We support an individual to their ability, not necessarily their disability. So for example, laundry. If an individual maybe can't do all aspects of the laundry. They can't pick their dirty clothes up off the floor and put them in their hamper. They can't carry their hamper. They can't physically carry their hamper to the laundry room. Maybe we support them with what they can do. So maybe if they're in a wheelchair, they can hold it in their lap while the staff support them in going to the laundry room. Or maybe they can sort the whites from the darks. Maybe they can measure the laundry detergent, if not exactly put it in. So supporting the individual with what they can do. We also provide opportunities for choice regarding daily activities. So what day support they attend, what activities they do, what they do in their leisure time, also meals and friendship. So what they get to have a choice in what they're eating, and who they're interacting with and how they're interacting with them. And the final standard is kind of the easiest one. It's choice regarding services and and providers. So what this means is that individuals have informed choices regarding services and providers. How do we do this? We provide comprehensive and understandable information regarding services prior to an individual receiving services. We document this through the admissions paperwork as well as their ISP or their individual support plan. So residential providers have additional standards that they need to meet under HCBS. Individuals living unit can be owned or rented via a lease or lease-like agreement. So all the individuals that receive residential services from us have a lease. They have privacy in their sleeping or living units. So they should have keys to their bedrooms as well as the key to like the front door and or the back door if the house has one. They have a choice of roommates, and they have the freedom to furnish and decorate their home and their bedroom as they would like to. They also have the freedom and support to control their own schedules and activities. This includes access to food 24/7. They may have visitors of their choosing at any time, and the setting has to be physically accessible to the individual. So an individual in a wheelchair needs to be able to access, all aspects of the home that are necessary for ADLs, like the laundry room, bathroom, kitchen, obviously, but also, able to go outside. If there's a steps to the porch, then we need to have a ramp to ensure that that setting is physically accessible to an individual in a wheelchair if they live there. If there needs to be a modification due to health and safety, it has to be justified and documented in a person-centered service plan. So in summary, DBHDS is the state level and HCBS is the federal level, and they have written regulations and standards to ensure the rights of individuals with disabilities. Any employee of the human services field is a mandated reporter and must report suspected abuse or neglect. Human rights allegations must be reported to the social work department immediately. Social work department must report any human rights allegations to the state within 24 hours of the incident. Again, the health and safety of the individual is the #1 priority. So if necessary, secure their health and safety first and then report once it's safe to do so. It's not a DSP's responsibility to determine whether or not something was a violation, but it is a DSP's responsibility to provide a safe environment and report any suspected abuse. So your role is to be trained in human rights upon hire and annually thereafter, to understand and comply with the regulations, that means both DBHDS and HCBS, to protect the rights and keep people free from abuse, neglect, or exploitation, cooperate, including confidentiality with any investigation or process, help individuals exercise their rights, and respect and report. You're a mandated reporter. If you have any questions regarding human rights, whether they be the DBHDS regulations or HCBS, feel free to contact myself or the social worker for your program. We are happy to provide clarity when we can. So yeah, thank you.